Great, thank you so much for having me to have the opportunity to talk, but also to do the massive pleasure and justice, hopefully, to represent Newcastle PSRC at this event, and also to close off the final research showcase of the day. So I'm really looking forward to sharing a bit more. So I've just been reflecting a lot on what's been an absolutely brilliant day. So thank you to the organisers for showcasing such great diversity and examples. My example is going to take a slightly different lens, and we're going to talk about an evidence synthesis approach that we did. So I can't take all of the kind of credit for this role. I supervised it, but it was me and a team together, and I'll speak a little bit more about that in a second too. So I always start my talks off by saying a little bit about me really quickly, because I think we're in a really privileged position, aren't we, as researchers? And also in a privileged position to be able to share the findings of the work that we're doing. And I always want to start off by doing that. And actually, I don't know if you can already tell by my accent, but I'm actually really privileged, born, bred in the Northeast, and I'm very proud to champion that. And actually, some of the speakers earlier today alluded to the fact that actually within the Northeast, there's a massive degree of deprivation. We know a lot of outcomes are potentially a lot worse for us as people living there. So that's a real example of me as a person in that place. So I always want to champion that because I'm very proud to be from the Northeast. I'm Anna, please call me Anna, and I use pronouns she, her. And I'm really pleased you introduced me as a pharmacist because I'm very passionate to be a pharmacist, and I don't think we've heard from a pharmacist yet today. But my wide-ranging experiences of being a pharmacist has given me the absolute pleasure of meeting, working with, and providing care for a massively diverse group of people. And I'm always really passionate about making sure that I phrase it, that I'm working with them, and working with them to come up with good care options, but also with my researcher hat on, working with them to really start highlighting their own lived experiences, all of the things around their experience that they can bring to the table and really voice their true reality that they're facing. And I think we're all really privileged as researchers to be able to do that, aren't we? Now, I'm speaking today around a project that talks around homelessness, and I don't have any personal lived experience of this, but I worked with a team including people who do, and so it's important that I mention that too. And speaking of my team, I'm working with Tasnim. So Tasnim was actually an undergraduate pharmacy student working with me on her dissertation project, and this is fed into this bigger work. And Kai, like I say, has that lived experience, but also has a career based on supporting others. So I think it's really my pleasure to share and shout about them too. So yeah, my project today that we're talking about is tackling inequalities and accessing medicines for people who are experiencing homelessness. And why have we really focused around that? Well, actually, I wanted to put a picture on the screen. Some of you might have seen this picture before. This is quite a famous image of a person experiencing homelessness based in Manchester, actually. And this was taken on Christmas Day a couple of years ago. And I thought that was a really fitting way to kind of summarise a little bit about the people that this work really centred on. And so we know, actually, if we look globally, the growing incidence around experiences of homelessness, if we put a number on that, actually, right now, globally, they're thinking it's around 100 million people each year alone. And we know that homelessness brings a massive impact on a person's health. So not only are they potentially living in closer proximity to infectious diseases, potentially experiencing poor health outcomes in relation to inadequate nutrition, the place that maybe that they're residing in that moment in time, potentially definite instances around reduced safety, and certainly around poor hygiene, or maybe experiences less restful moments. And I think it's a massive area that really, despite us knowing all of this and knowing the very clear detrimental relationship that homelessness has, there still remains under-researched representation from members of this community within our work. And so really, if we start to think about the question on the screen there, what is the impact of homelessness on health and social care? So actually what it means in the reality is that people are less likely to use and/or to engage with mainstream primary care. And that's globally. But if we look specifically within the UK, that people experiencing homelessness are 4 times more likely to visit hospitals for emergency care. But interestingly, they are 40 times less likely to be registered with a GP. So therein lies a really interesting dynamic there, doesn't it? And actually, if we look globally, what people are saying is that these inequalities are being attributed to barriers affecting people being able to access services, but also the absence of services being tailored with these people in mind. And therein lay the kind of reason as to why I approached this. And like I say, we're approaching this from an evidence synthesis perspective. So for methodologists in the room, we did a meta-ethnography and a qualitative systematic review. This work's been published, and you can access the paper using that QR code. So if I'm just break down the methods ever so slightly, we focused very clearly around developing an understanding of what are the barriers that people particularly are facing in relation to medicines. So how are they accessing medicines and health-related services relating to a medicine? And we're also wanting to unpick a little bit around, is there something in there that's enabling them, and potentially any interventions that are aimed to try and lessen that gap. And we focused very much on the evidence that existed around experiences from a lived experience perspective, members of that community, but also we included data and evidence for people who are providing those kinds of services, because we wanted to know a little bit more depth around those. We didn't place any restrictions on the populations that these studies focused on. But we defined homelessness to fit the criteria from Fentasa around rooflessness or houselessness at that moment. And I wanted to just share a little visual of the findings. So meta-ethnography, you're pulling together overarching themes from the published literature. So this isn't us going out there and getting this data, this is us synthesizing what's already out there. And from that, we identified 3 key themes or third-order constructs. And I just wanted to briefly give you a flavor of those voices that underpin the development of these themes. So the first theme was based around discrimination, stigma, and barriers that were experienced when accessing current services. And I just wanted to share you a little lived experience snippet here. So I don't know if you want to have a read along, but I'll read it out for you. So I was once sitting in a doctor's surgery waiting to see a doctor with my wife. Someone else came in and the receptionist apologized to her for there being 2 drug users in the waiting room, and that was in front of them. I don't think I really need to speak much more around the kind of stigma that individual faced and how they possibly were felt in that moment. But therein lies a definite barrier in place affecting that individual. The next theme that we pulled out was around actually the ability of someone to be able to take medicine safely. And taking medicine safely means that they can store them safely, that they understand a little bit more around potentially what affects their behaviour in taking that medicine, and then also possibly tackling some mistruths that come out here. And so I wanted to share this snippet from a gentleman that he described living out of a backpack without anywhere safe as a safe place to keep their medication. And for healthcare professionals amongst us in the room, we very commonly prescribe, dispense and supply 30-day prescriptions, don't we? But actually is 30 days worth of a medicine really the safest way to provide medicinal care? And this gentleman described if backpacks or belongings come up missing, actually what's the impact there on having a continued supply? And then the final theme in this study was based around the delivery of the services. So how are people actually tackling that? We had earlier from Hester that image there of describing this population as a hard-to-reach group, but actually maybe we need to start changing some terms and language around that. And actually this reflected here when, in terms of outreach services that existed to help and support people experiencing homelessness. And one person shared actually in an outreach centre that they felt safe in that place and they felt comfortable in that building. And there's not a lot of places in that place they lived where they did feel comfortable, because you meet every waif and stray and a bad on the way up there, and you might bump into the wrong people. So I think that amplified to me a lot around, yes, it's the reaching out, yes, it's the providing an outreach service, but where is that based? What does that look like? And we definitely have a lot of scope to improve things there too. And so actually, from a take-home message perspective, there's definitely a degree of proactivity involved in this. The destigmatization and language and terminology came across really quite prominently, and it's definitely been something that's checked in my personal radar in the way I'm describing, and it's been such a pleasure to just have an insight, although I'm not meeting and working with these people directly, but just to understand it a little bit further, because I will admit it was an area that I hadn't necessarily worked in previous to this work. It certainly left us with a point of reflection around how we can provide pharmacy-based care in an outreached way, and I guess watch this space for some more work that's coming from Newcastle around that. And also one of my big personal passions around my own personal research is to consider these extra cultural nuances that actually will intersect and affect people directly. But I will caveat that this work didn't necessarily focus in depth in those. The reason for that is because that level of work hadn't already existed. So therein lies a big message to us that we need to be the ones going out there and doing that in order for evidence synthesis to then pull things together. And so I just wanted to finish, I guess, in saying it's been a massive privilege and pleasure to share this work. Massive thanks to my co-authors, because it wouldn't have been possible without. And yeah, watch this space for more work coming on this from Newcastle. Thank you.